social media மற்றும் snake bite പറ്റിയിട്ട് മറ്റുള്ള ഒരുപാട് ഇഷ്യൂസ് വരുന്നത് കാണുമ്പോൾ പബ്ലിക് അവയർനെസ്സും നമ്മുടെ ഡോക്ടർമാരുടെ ഇടയിലുള്ള അവയർനെസ്സും ഒക്കെ ആവശ്യമാണ് എന്ന് കരുതിയിട്ടാണ് ഈ ഒരു ടോപ്പിക് സെലക്ട് ചെയ്തത്. അതിന് വളരെ മികച്ച ഒരു ടീം പാനലിസ്റ്റുകളെ നോക്കുന്ന തൊഴിലുണ്ട്. നമ്മുടെ ഇന്നത്തെ പ്രോഗ്രാമിൻ്റെ മോഡറേറ്റർ നമ്മുടെ സെക്രട്ടറി ഡോക്ടർ തന്നെയാണ്.
Very good evening all. So like how our president told, the burning issue now, whenever we are reading newspapers, opening social media, everywhere it is about snake bite. So the number of snake bite cases are increasing now, and some of our members also suggested that we should have something regarding that. So we all know most of you would have managed snake bite. So this is just a session so that we can refresh our knowledge and know about the latest protocol, what are the standard guidelines. So with this introduction, we'll start our panel discussion. So the first question is to Mr. Manoj. Why snake bite cases are increasing now?
Good evening all. Basically, if you talk about snakes, snakes had evolved around 150 million years back, and they are cold-blooded. So the basic main reason for you to get snakes inside the house at this point of time is just because of the heat factor. Snakes can't stand heat as well as cold. You know, they're cold-blooded, right? But they can't stand inside the water. They prefer normally dry areas and cooler weather. That's the main reason why we get to see snakes very frequently. Snakes had evolved from an aquatic lizard, and we can see two traits of the evolution still with snakes. They all can swim, and they all climb. So the main reason for them to get inside the house is looking for drier, you know, if it's a rainy season, they prefer to stay in dry lands. And in summer now, there's a question right now that why they are coming out of the burrows, you know, because if the outside temperature is around 35-40, the burrows will have a temperature around 38 or below that. And, you know, normally snakes become docile after having a meal because the metabolism is very slow and they prefer to stay alone, and they are solitary basically. Snakes come in pair only at the time of mating, otherwise they live a solitary life. And one reason, because of the heat, you know, the embryo develops very faster in the eggs, and normally 32 to 34 degrees is the temperature what is ideal for a snake to grow from an embryo to a developed snake. But because of the high temperature, we can see a lot of you know, egg hatching before time. That means this is not the right time. Actually, beginning of monsoon they normally come out, and whichever snakes are coming out, and off late whatever snake bites have been reported is from juvenile snakes. There's a misconception that, you know, juvenile snakes won't have venom, or their venom potency is comparatively lesser. It's wrong. The venom content or the volume of venom is much lesser, but the potency is very high. We need to you know, take it seriously. In a bite case scenario, we need to administer the same amount of ASV as doctors. I need not talk that part, but yes, the treatment is same whether a juvenile snake bites or not. Only difference is about the volume, and once the snake develop into a larger adult snake, the potency slowly reduces and the volume increases. That's a normal trend. Now the measures to keep snakes away is to keep our surroundings clean, keep rodents away, close the burrows, and again creepers, all those stuff, you know, We keep a lot of ornamental plants in front of our house, normally on the steps where we water them. The atmosphere will be moist because of that. And as I said, snakes can't stand heat, so they normally prefer to take such spaces as hideout. And eventually when we are coming out, they bite us. In the role, the snakes don't see us as a prey. So only for defense they bite. And some cases, obviously, dry bites happen. Otherwise, yes, venom is injected. And to keep them away, the best part is to keep rodents away. We get to see a lot of repellents these days. Everybody on social media comes out with advice how to make a repellent, and a lot of things are sold on platforms where the reality is nothing works. There's no 100% repellent which is available to keep snakes away. Only thing is to keep the surroundings clean. There are personal measures and environmental measures. Personal measures are like wearing a shoe, keeping a torch, and the buildings. Normally we spend a lot of money on the main door, the front door. 4 or 5 lakhs we spend to get one door, and the remaining, when we go to field, we see a lot of houses behind. The main entry point is the kitchen door, and most of the cases that will be a grill or a normal plywood door, which sometimes might have got damaged, and snakes can slither in from there. And obviously food and hiding space is what attracts them to our space. So basically, we need to, it's food what attracts mainly. And the case of the 2 youngsters who were sleeping inside the house, and one brother got bitten by a kite. The reason is, kites get attracted to a wolf snake known as wolf snake, which is very common inside the house. They normally, have rodents, and the main thing is lizards and their egg. So a wolf snake get inside the house. Snakes can't smell like us, so they use the forked tongue, and they preferably follow the smell and get inside. And ultimately we end up, normally kites are nocturnal and they are very docile and shy creature, but yes, when we try to handle them, they normally wriggle and try to bite us. Otherwise they are very docile. What we in the field, what we come to see is Russells. Again, they are known as 360. They can turn and bite without any provocation. They can bite, and again the frequency of bite is much higher. So basically, to diffuse the situation, the best way is to keep rodents away and take safety measures. Thank you.
Thank you. Next, so earlier, it's like when we were studying and all also, as soon as there's a snake bite case, we are like, okay, bring the snake. First we have to identify, and we can manage accordingly. So now the guidelines is more or less, it's going towards syndromic management. That is, we are not sure whatever snake they have caught is the one which has bitten. So the snake bite clinical manifestations itself, they have divided into 4 syndromes. One is hemotoxic with bleeding manifestations. The next is neuroparalytic, then progressive increase in swelling, and the last one is myotoxic. So I would like to ask Dr. Abhilash, what are the clinical features of hemotoxic envenomation and how to monitor a case with hemotoxic envenomation?
Snake bites is a very terrible alarm. So we should all know about how to do a syndromic approach for the snake bite management. So first we discuss about the hemotoxic snake bite and what are the clinical features. So the most important thing is whenever a snake bite patient with snake bite comes to you, we have to see the circulation, airway and breathing. That is the most important thing. That the patient is stable, the patient is developing any complications of the snake bite. So what we do is we first see the vitals and the respiration, etc. If that is stable, first we will go to the local where the snake bit, the bitten area. So the bitten area in hemotoxic bite, that is it is rhesus viper, soft-scale viper, and you see the pit vipers are also very commonly bite nowadays. pit viper, Sumner's pit viper, Malabar pit viper, different types of them. So the local reaction is usually, actually it's very high in cases of vipers. So the swelling will be more compared to the neurotoxic snake bite like crate. You may not get swelling in case of crate. So there will be swelling at the site. That there will be bleeding from the bitten site. Then later the can progress. The swelling can progress and produce necrosis. Sometimes even compartment syndrome. So you should look at the whether the patient had developed compartment syndrome, especially in distal limbs. When bitten, the swelling can cause compromised arterial supply, and the symptoms of compartment syndromes will be like pain on passing movements. You may get pulses may be absent. Look for pulses. Then you may get tingling sensation or numbness over that area, or reduced sensation, hypoesthesia. And that is very important. And always there may be ligages may be there on the that is very common, and I think the first aid part will be deal with. So the ligages, if it is there, don't try to remove it immediately. Only if the patient is having features of envenomation, definitely we will start ASV. If we are going to start ASV or the patient is having features of envenomation, you start ASV and then only remove the ligature. Otherwise, this venom can spread very fast. If there is no signs of envenomation, we can remove the ligature very slowly with the help of BP phosphorus. So the next thing is we should look for the other problems like lymphadenopathy. So these hemotoxic bites, lymphadenopathy is very common. So the daily lymph nodes we have to examine. Then look for whether there is any bleeding manifestation. The bleeding signs are gingival bleedings may be there. Subconjunctival hemorrhage can be there, palatal bleeding, hematuria, hemoptysis, etc., and the bleeding from the local sites also will be there. So all these things we should look for. So if, then the patient may have the symptoms like abdominal pain or vomiting. That is also a feature of envenomation. And then sometimes patient may have retroperitoneal bleed and all. So in that case, there will be hypertension, abdominal pain, etc. So abdominal pain and vomiting should be taken very seriously because there is a chance for retroperitoneal hemorrhage. Then in the later stage, as the envenomation progresses, along with the bleeding manifestation and coagulopathy, including disseminated DAC can develop. And the another important symptom is capillary leak syndrome, where you can get the extravasation of the plasma and the proteins from the arteries into the interstitial tissue, and the patient may develop facial puffiness, conjunctival chemosis, then even ascites, pleural effusion. There will be hypotension. The patient may develop increased thirst, hypotension. All of these are features of this one, capillary leak syndrome. And when you do the blood examination, you will get a rise in hematocrit and one. So the next thing is the another complication is renal failure. So you always ask for the oliguria, hematuria, whether the patient is developing oliguria, hematuria. And if you look at the urine routine, you may get myoglobinuria, hematuria, albuminuria, etc. So the monitoring of these signs and symptoms are very, very important because in order to initiate anti-snake venom and also the management of all these symptoms. So the most important test we do in hemotoxic snake bite is whole blood clotting time, WBCT. If it is more than 20 minutes, that is considered as positive. I think the monitoring part and the treatment part I can.
What are the clinical presentation of snake bite in children, and what are the precautions we have to take when we are transporting a child, when we are referring or transporting a child?
Good evening, all. Let me thank IMA KANNUR for this opportunity. So children also know the amount of venom injected there is no difference, whether it is a child or whether it is an adult. But the body mass is definitely far lesser than what that of an adult. So the effect of venom will be much more in children. That is the number one thing. So while managing the drugs what we are using, that is ASV, that is the main drug we are using, those is same for the child and the adult patient. But just because of that, the side effect will be more. The side effect due to a drug will be more, and the chance of anaphylaxis is a little more in children than in adult. Then about the clinical features, majority of, because children and adults are entirely different, because majority of child won't complain the thing. We have to find out. So it is the parents and the physician to find out whether child is having the features of environmental, what Dr. Abhilash has already mentioned here. Whether it is neurotoxic or hematotoxic, especially neurotoxic, it is very difficult. Especially crane bite. You might have heard about a child died recently. Because majority of time they present, they otherwise it is called early morning neuropathic syndrome. Because when I was practicing COVID, we had a child, 4-year-old child brought in the morning with the vomiting and abdominal pain. That is very common because vomiting nowadays we are majority of the case, every pediatrician, as you will be knowing, every second case coming to our OPD is food poisoning. So it is very simple, easy to confuse this with the snake bite. So the first question what you have to ask is where the child was lying on. Because crate is notorious, they will bite only if you are lying down on the floor. They won't climb and bite you like cobra or other thing. So that is the one thing, but point towards bite. And unfortunately there won't be any bite mark in crate and there won't be local pain. So only the clinical feature will be child will complain, early morning child will be complaining, abdominal pain and vomiting. And while seeing the child will be looking tired. So we have to differentiate whether it is ptosis or this is drowsiness. How do you differentiate between, how can you differentiate between drowsiness and ptosis? Ptosis child, and one thing about snake bite, it is definitely in the early stage won't affect CNS. Your meditation, your everything will be absolutely normal. So child can communicate, but they cannot, sorry. And ptosis, child is trying to see you. So the eyebrow will be elevated. Child will be looking like this. So you can see the eyebrow and the wrinkles in the forehead you can see. When child is drowsy, there will be response. There will be just if it is due to vomiting or dehydration. Vomiting will be dehydration will be there. Then about the circumstances, just tell them never delay the treatment by looking around for the snake. If you have doubt, immediately take the child to nearest hospital. Then see that if child is having ptosis, definitely next thing going to happen is respiratory arrest, respiratory failure. So any child with the ptosis, definitely that child needs respiratory support. That is 100%. Then about the hematotoxic venoms. Hematotoxic, definitely child be having local reaction. That is very important whether he is alert or pediatric age. But one thing you have to say, insect bite is very common in pediatrics. Especially child is just playing outside, child be having, because they may not be knowing whether it's snake or something else. Some bite, sometimes Kori bite, Kori snake like that. Even still today we have 2 cases like that. So how do you differentiate between insect bite and snake bite? Because insect bite usually edema will be there or both. Insect bite pain will be less in insect bite, but definitely pain will be more in snake bite except crate. And if there is hemorrhage or any blebs or something, that is 100% sure that is snake bite. Usually insect bite there will be itching will be there and less pain will be there. And if, as Dr. Abhilash already mentioned, look for the secondary draining lymph node. That is very important. If draining lymph node is there, 100% sure it is snake bite. Immediately you have to shift the child to nearest hospital and give the medication. And what are the precautions we have to take while transporting the child? That's another most important thing. If you are working in a peripheral hospital or you are in a clinic or something, a child brought with a suspected snake venom, snake bite venomization, first thing that is do the right. What is do the right? Right is reassure. Reassure the child, or which child is elder one, reassure the child or the parents you reassure. And immobilization, and number one thing, Abhilash already mentioned, how to immobilize the limb. First thing is you can use scale or some straight rod or something, or even if nothing is there, you can roll the newspaper and you can splint it. And never use tourniquet. Dr. Abhilash already mentioned, never ever use tourniquet. And you can, otherwise you can use that crepe bandage so that you can put that splint inside and wrap it, and so that it should allow your one finger to go inside. So it should not be so tight. So then if time taken to nearest hospital is less than 30 minutes, there is no need for just splinting you do. It is more than 30 minutes, you are expected to reach the hospital within 3 hours. Definitely you have to splint and you have to transport the child. And while transporting thing, what you have to do is never give anything mouth. Why? What's the thing? Because if you give something by orally, child may vomit. That may there is chance for aspiration. So another thing is, if child is the other hospital, they may have to intubate the child. So while intubation, better not to give anything. Next is nervous start oxygen. That's the one thing. If you find child is having any difficulty in breathing or something, never start the oxygen. Because why? Because snake bite envenomation will cause non-oxidation failure. It is a type 2 respiratory failure. That is, it is a ventilatory failure. Though carbon dioxide retention is happening, it is not hypoxia, it is carbon dioxide. So while you are transporting, you just monitor the saturation. If the drop in saturation is more important than keeping the saturation 94 and above. So never give oxygen while transporting. You have to monitor very closely, you have to monitor and look for the neurological symptom which I already mentioned. Ptosis is the first symptom which you have occurred. Then child will be having dysarthria, dysphonia, diplopia, then dysphagia and dyspnea. All these 5 Ds you see. Then last thing is paralysis. We should not allow a child to go for paralysis. And if ptosis occurs, definitely child needs respiratory support in the form of bag and mask, or you can use laryngeal. If nothing is there, you get if child is transporting from any faraway place, immediately drop child to any nearest hospital where there are facilities for ventilation. Definitely, almost every hospital we have a surgeon and anesthetist. So anesthetic will be there. Get the child ventilated. If adequate size ventilator, this tube is not available, you can get laryngeal mask this thing. Then that's cost only 1,500 rupees. That is when then with that you can give bag and mask ventilation, transport the child to safely to the nearest hospital. And another thing is there is local reaction, and you have the facilities to give ISV. Never give ISV while transporting the child, because at any time anaphylaxis can affect child can become bad. So never give an ISV while transporting the child. If you want to give ISV, give completely in the clinic itself or hospital itself, then transport the child to nearest higher center or tertiary care center. So never try to give it while transporting, and secure IV line. That is very important.
Thank you, sir. Next question to Dr. Renoy. So, sir has already discussed the clinical manifestations of neuroparalytic snake bite. So, I want to ask, what are the clinical situations in which the snake bite victim might require urgent resuscitation? And could you just describe regarding the LMA what just sir mentioned?
First of all, thank you, Yemi, for giving me the opportunity to talk here. So, as Nandomar sir said, neuroparalytic cases, neurotoxic envenomation, the major issue is impending respiratory failure. How can you identify that earlier and take a precautions? And how fast it can develop? So, basically, if there is crate and cobra are the major neurotoxic snakes that we have. Slight difference, usually cobra venom is something called, this acts in the neuromuscular junction, Cobra venom is usually post-synaptic. Crate is presynaptic toxin predominantly. And cobra venom usually acts much more faster, like in 30 minutes to 1 hour it can progress. That's why even when it is a child, it goes very fast. That's what, as sir said, happens like to fast progression. Crate bite, it is somewhat slower, 6 hours to 24 hours it can take. So when you are having a neuroparalytic signs of ptosis and all, do not think it can progress very fast. So you have to take an early precaution. What you can do is, if this there is when patient is reached hospital, you can check for the ptosis, diplopia, external ophthalmoplegia, these kind of signs. And to look for muscle weakness, you can look for patient's ability to lift up his neck. That weakness is there. That is also an indicator of impending respiratory failure. Then next thing is, you can do the single breath count test. Single breath count test, usually patient is taking a normal breath, and it is difficult in children, but you can do it in, if it is less than 15, that shows probably patient is going for impending respiratory failure. So in such things are there, do not wait too much. A crash intubation is much more difficult and dangerous than an early elective intubation. Okay? So we'll go for early elective intubation. That's what we usually do. At least, even if you are not able to intubate, the important thing is to maintain ventilation. How can you maintain ventilation if you cannot intubate? You can use either simply bag and mask ventilation with an ambu bag, or you can do an LMA. LMA is, as mentioned, this is an LMA. It's a laryngeal mask airway. This is somewhat easier to put than an intubation, an endotracheal intubation. So basically, it is different sizes are there. Usually it is written. This one is a size 5. It is for 70 kg to 100 kg patients. So based on the weight, you can choose what size of. It is available from even 2, 2.5, 3, 3.5 like that. So you can decide that if you put, it's somewhat easier. You just hold it like this. Can use it. This one is expired.
Expired out.
Yeah. Okay.
Expired.
Expired. Okay. So you hold it like a like holding like a pen. Okay. Open the mouth. Just put some jelly here and slide it along the posterior pharyngeal wall, posterior oral your palate, and slide it. It will go there and reach the over the larynx. It will keep at the laryngeal mask, and then you can ventilate. It's simple. No need of any laryngoscope or not. So ventilating the patient while transporting and after reaching the hospital, you decide whether the patient is going for impending failure. That is the major treatment. The other main treatment is, obviously, it is the anti-snake venom. ASV. Dose of ASV, as sir mentioned, first dose is, in our WHO and Indian guidelines say around 10 vials of ASV is the first dose, and usually within 1 hour there should be improvement in symptoms. If that is not there, you can give another 10 vials, not more than that. That is the neurotoxic envenomation maximum allowed dose in the current Indian and WHO guidelines. The third thing is, you can give neostigmine. Neostigmine usually will work only in the postsynaptic case, like in cobra envenomation, it might work. You can give a combination of neostigmine and atropine. Atropine or glycopyrrolate can be combined with neostigmine. But it will not work in crate bites, which is a presynaptic toxin. So these are the medications that you can use for and treatment you can use for neurotoxic envenomation.
Thank you, Dr. Renoy. Next, to Dr. Manu Matthews. GMC Pariyaram is one of the center in government sector where they are managing large number of cases in the district. So, what are the challenges which you face while managing cases at Pariyaram?
First of all, I would like to thank IMA KANNUR for calling me as a panelist. Challenges in snake bite. Actually, when I joined Pariyaram some 22 years back, there also our treatment wise it is almost same. We give the polyvalent venom. We don't have the monovalent. For the big four snakes, we have the polyvalent venom. That part it is same. But there is a lot of challenges. One challenge is there is a loss of golden hours. Earlier, when I used to practice, I used to see so many cases going to other quacks and wasting the time. But nowadays it is very, very less. ആ സമയത്ത് ഒരു കല്ലെല്ലാം വെച്ചിട്ട് കല്ലെല്ലാം സ്നേക്ക് സ്റ്റോൺസ് എല്ലാം വെച്ചിട്ട് പയ്യന്നൂർ ഭാഗത്തു നിന്നൊക്കെ പേഷ്യൻസ് വരുമായിരുന്നു. ഇപ്പം അങ്ങനെയൊന്നും കാണുന്നില്ല. അതുപോലെ ഒരുപാട് മറ്റ് സ്ഥലങ്ങളിലെല്ലാം ഒരു സ്നേക്ക് ബൈറ്റ് ആണെങ്കിൽ നോൺ പോയിസണസ് ആണെന്നെല്ലാം വിചാരിച്ച് കുറേ ഡിലേ വരും. പിന്നെ വേറെ മറ്റ് നാടൻ ചികിത്സാ രീതികൾ പരീക്ഷിച്ചിട്ട് വരുന്നിട്ട് കോംപ്ലിക്കേറ്റഡ് അങ്ങനത്തെ കാര്യങ്ങൾക്കും വളരെ കുറവാണ് കാണുന്നത്. പിന്നെ ഒരു വലിയ ചലഞ്ച് ന്യൂറോടോക്സിക് സ്നേക്ക് ബൈറ്റ് ആണ്. വൈപ്പർ ബൈറ്റിന് വലിയ പ്രശ്നമില്ല, നമുക്ക് സമയം കിട്ടും. ഇപ്പം ഹെമറ്റോടോക്സിറ്റി ആയിട്ടും എല്ലാം കൂടി വന്നാൽ നമുക്ക് കുറച്ചൊരു ടൈം കിട്ടും. പക്ഷെ കോബ്രയാണെങ്കിൽ ഇറ്റ് ഇസ് ഫാസ്റ്റ് ന്യൂറോപൈറസിസ്. ഒരു 20 മിനിറ്റ്സിൽ തന്നെ അതങ്ങ് തുടങ്ങും. പിന്നെ ഒരു പ്രോപ്പർ ഹോസ്പിറ്റൽ കെയറിൽ എത്തുന്ന സമയം കിട്ടിയില്ലെങ്കിൽ അപ്പോഴേക്കും പേഷ്യൻ്റ് ഡെത്തായിപ്പോവും, അല്ലെങ്കിൽ അത്രയും സിവിയർ ഡാമേജ് ഓൾറെഡി വന്നു കഴിയും. Even recently, so many deaths has been there. Most of it's due to neurotoxic snake bite. That is a very big challenge, and now we are trying to overcome it by other ways. One is that Dr. Rene showed that LMA or laryngeal mask. അപ്പോൾ നമ്മൾ വിളിക്കുന്നത് 108 വിളിച്ചിട്ടാണല്ലോ വരുന്നത്. 108 വിളിക്കുമ്പോൾ അവിടുത്തെ ഒരു മെഡിക്കൽ അസിസ്റ്റന്റ് ഉണ്ടാവും. ഹി ഈസ് ബീങ് ട്രെയിനിങ് ഓൺ ദിസ് ഹൗ ടു ഗീവ് LMA. എന്നുവെച്ചാൽ ശരിക്കും ഇൻറ്റുബേഷൻ ആണ് ചെയ്യേണ്ടത്, പക്ഷെ അതൊന്നും പ്രായോഗികമല്ല. അങ്ങനത്തെ റൂറൽ സെറ്റപ്പിലൊന്നും അവിടെ ഇല്ല. അപ്പം ഈ LMA എന്ന് പറഞ്ഞാൽ വളരെ എളുപ്പമാണ്. ആർക്ക് വേണമെങ്കിലും ജസ്റ്റ് അത് ഇൻസേർട്ട് ചെയ്താൽ മതി, പിന്നെ ആ കഫും എല്ലാം ഇൻഫ്ലേറ്റ് ചെയ്താൽ മതി. പിന്നെ അതിലൂടെ നമുക്ക് വെന്റിലേറ്റ് ചെയ്യാൻ ആംബിൾ ബാഗ് വെച്ചിട്ട് വെന്റിലേറ്റ് ചെയ്യാൻ പറ്റും. അപ്പം അത് ട്രെയിനിങ് കൊടുക്കുകയാണെങ്കിൽ തന്നെ നമുക്ക് ആ ചലഞ്ച് കുറെ ഓവർകം ചെയ്യാം. പിന്നെ ഒരു പ്രധാന ഒരു പ്രശ്നം വെച്ചാൽ നമ്മുടെ കണ്ണൂരൊക്കെ ഒരുപാട് പിറ്റ് വൈപ്പർ ബൈറ്റ്സ് ഉണ്ട്. ഒരു ഏകദേശം പരിഹാരത്തിൽ വരുന്ന ഒരു 30% പിറ്റ് വൈപ്പർ ബൈറ്റ്സ് ആണ്. അത് പിറ്റ് വൈപ്പർ എന്ന് വെച്ചാൽ മെയിൻലി ഫോറസ്റ്റ് ഏരിയാസിലെല്ലാം കാരണം നമ്മുടെ ഈ വെസ്റ്റേൺ ഗാട്ട് ബെൽറ്റ് ഉണ്ടല്ലോ, അവിടെ ഒരു മലയോര മേഖല, അവിടെ നിന്നൊക്കെ ഒരുപാട് റബ്ബർ പ്ലാന്റേഷൻസ് ഒക്കെ ഉണ്ടാകുമ്പോൾ ഈ കരിയിലകൾക്കിടയിലാണ് പിറ്റ് വൈപ്പർ വരുന്നത്. പിറ്റ് വൈപ്പർ ബൈറ്റ് ഒരുപാട് കേസ് വരുന്നുണ്ട്. അതിൻ്റെ ഒരു പ്രാധാന്യം എന്താണെന്ന് പറഞ്ഞാൽ നമ്മൾ സാധാരണ കൊടുക്കുന്ന ASV അതിന് കവേർഡ് അല്ല. അപ്പോൾ നമ്മൾ കൊടുത്തിട്ട് വെറുതെ റിയാക്ഷൻ ആവുക എന്നല്ലാണ്ട് വലിയ കാര്യമില്ല. അപ്പം ഏർലിയർ ഇതിലൊക്കെ ആണെന്നുണ്ടെങ്കിൽ പെരിഫറി എന്നൊക്കെ ഒരുപാട് പിറ്റ് വൈപ്പറിനും അവർ പാമ്പിനെ കൊണ്ടുവരുവാണെങ്കിൽ ഫോട്ടോ കാണിച്ചാൽ തന്നെ ASV കൊടുക്കുന്നത് കാണുക. പക്ഷെ ഇപ്പം അങ്ങനെയല്ല. ഇപ്പം അത് എല്ലാവരും കുറേയും കൂടെ അവെയർ ആയിട്ടുണ്ട്. പിറ്റ് വൈപ്പറിന് ഇപ്പം അങ്ങനെ ഇത് ASV കൊടുക്കുന്നില്ല. അങ്ങനെ കുറച്ചും കൂടെ ഒരു നല്ല കാര്യമാണ്. സോ ദീസ് ആർ ദ മേജർ ചലഞ്ചസ്. പിന്നെ ഒരുപാട് ക്ലിനിക്കൽ ചലഞ്ച് ഇഷ്ടം പോലെ ഉണ്ടാവും. ഫോർ എക്സാമ്പിൾ നൈറ്റിൽ ഇതേപോലെ ന്യൂറോടോക്സിക് ബൈറ്റ് സസ്പെക്ട് ചെയ്തിട്ട് വന്നു. നൈറ്റിൽ വന്നിട്ട് വാട്ട് ഐ ഡു ഇസ് ദാറ്റ് ഐ മേക്ക് ദ bystander, tell him that always every 1 hour you just wake up the patient, ask whether there is any discomfort. എന്നുവെച്ചാൽ രാത്രി ഇരിക്കുമ്പോൾ ടോസിസും ഉറക്കം തൂങ്ങുന്നതും തമ്മിൽ കണ്ടുപിടിക്കാൻ വലിയ പാടാണ്. അപ്പൊ നമ്മൾ മിസ്സായി പോയിട്ടുണ്ടെങ്കിൽ പേഷ്യന്റ് മുകളിൽ കിടന്ന് ബെഡിൽ കിടന്നുറങ്ങും, ബൈസ്റ്റാൻഡർ താഴെ കിടന്നുറങ്ങും, രാവിലെ ആകുമ്പോഴേക്കും റെസ്പിറേറ്ററി പാരലിസിസ് വന്ന് കഴിഞ്ഞിട്ടുണ്ടാവും. അങ്ങനെ എപ്പോഴും ഇത് യു ഷുഡ് ബി വെരി 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 അവെയർ ഓഫ് ദാറ്റ്. എപ്പോഴും നമ്മൾ ഓൺ ദ ടോസ് ആയിരിക്കണം ആസ് എ ക്ലിനിഷ്യൻ. ദെൻ ദ ടൂണിക്ക് സാധാരണ നമുക്ക് പണ്ടൊക്കെ നമ്മൾ വെച്ചിട്ടുണ്ടെങ്കിൽ ഒരു പാമ്പ് പിടിച്ചിട്ട് അതിൻ്റെ മുകളിലൊരു കെട്ടിടുക എന്ന് പറഞ്ഞിട്ടുണ്ടെങ്കിൽ ലോജിക്കലി ഇറ്റ് സീംസ് ഫൈൻ. വെനം താഴ്ന്ന് വരുന്നു, നമ്മളൊരു ടൂണിക്ക് കിട്ടുന്നു, വെനം അവിടെ നിൽക്കുന്നു. ബട്ട് ദ പ്രോബ്ലം ഈസ് മോസ്റ്റ് ഓഫ് ദ പീപ്പിൾ ഹൂ അപ്ലൈ ദിസ് ടൂണിക്ക് ഫ്രം ദ പെരിഫറി, ഇപ്പം നാട്ടുകാരൊക്കെ ആയിരിക്കും അത് വരുന്നത്, ദ അൺട്രെയിൻഡ് പീപ്പിൾ. അപ്പം അവരെന്ത് ചെയ്യും, വളരെ മുറുക്കിയിട്ട് അങ്ങ് കെട്ടിടും. സോ ഇറ്റ് ബിക്കം എൻ ആർട്ടിക്കുലർ ടൂണിക്ക്. ഇറ്റ് വിൽ കോസ് എ decreased perfusion distally and the patient may lose his limb. ചിലപ്പോൾ ചേര അടിച്ചിട്ടായിരിക്കും വരുന്നത്, പക്ഷെ ഇത്രയും മുറുക്കി കെട്ടുന്നതുകൊണ്ട് ലിംബ് ചിലപ്പോൾ ആംപ്യൂട്ടേറ്റ് ചെയ്യേണ്ടി വരും. ഇങ്ങനത്തെ കുറെ കേസെല്ലാം വന്നത് കൊണ്ടാണ് ഇപ്പോഴത്തെ ഗൈഡ് ലൈൻസിൽ വേണ്ട, ഇത് നിങ്ങൾ ടൂണിക്ക് ഇടുകയേ വേണ്ട എന്ന് പറയുന്നത്. അല്ലെങ്കിൽ ആക്ച്വലി അത്രയും ട്രെയിൻഡ് ആയിട്ടുള്ള ആളായിരിക്കണം, അത് നമുക്ക് എക്സ്പെക്ട് ചെയ്യാൻ പറ്റുള്ളൂ. പിന്നെ ഈ പ്രഷർ ഇമ്മൊബിലൈസേഷൻ എന്ന വേറൊരു ഇതുണ്ട്. പിന്നെ മുറുക്കി ചുറ്റി കെട്ടി ഇത് ഒരു ബാൻഡേജ് പോലെ കെട്ടിയിട്ട് വളരെ മുറുക്കി കെട്ടുന്നത്, അത് ഇലാപ്പിഡ് ബൈറ്റ്സിനൊക്കെ, കോബ്ര അതിനൊക്കെ പറ്റും. പക്ഷെ നമ്മുടെ ഇവിടെ മെയിൻ ആയിട്ടുള്ള വൈപ്പർ ബൈറ്റ്സിനാണ്. അത് വൈപ്പർ ബൈറ്റ്സിന് അത്ര എഫക്റ്റീവ് അല്ല. പിന്നെ ഇമ്മൊബിലൈസേഷൻ, ഇപ്പം നേരത്തെ പറഞ്ഞു റൈറ്റ് അപ്രോച്ച് എന്ന് പറഞ്ഞു, ദറ്റ് ഇസ് വെരി ഗുഡ് തിങ്, ബട്ട് ഇറ്റ്സ് വെരി ഡിഫിക്കൾട്ട്. എന്നുവെച്ചാൽ ആകെ പാമ്പ് അടിച്ചിട്ടുണ്ടെങ്കിൽ എല്ലാവരും ചെയ്യും, ഉടനെ ഓടുകയാണ് ചെയ്യുക. ഓടുമ്പോഴേക്കും എന്ത് പറ്റും, പെട്ടെന്ന് വെനം എല്ലായിടത്തും പറയും. ഇപ്പോഴത്തെ ഗൈഡ് ലൈൻസ് കഴിയുന്നത്ര ഇമ്മൊബിലൈസ് ചെയ്യുക, എസ്പെഷ്യലി ദ ബിറ്റൺ പാർട്ട് ഷുഡ് ബി ആസ് try not to move it. But if the person is running for some time or walking for some time, then the venom is all will spread. Then after that you are going and immobilizing it, അത്ര ബെനിഫിറ്റ് ഉണ്ടാവില്ല. ഇവിടെ മഴ പെയ്ത് കഴിഞ്ഞിട്ട് പിന്നെ കുട ചൂടാൻ കൊടുക്കുന്ന പോലെയാണ്. അപ്പോഴേക്കും വെനം എല്ലാം പടർന്നു കഴിഞ്ഞിട്ടുണ്ടാവും. അപ്പോൾ പിന്നെ ഇമ്മൊബിലൈസേഷൻ്റെ ഒരു ബെനിഫിറ്റ് കിട്ടുന്നുണ്ടാവില്ല. ഓക്കെ.
Thank you, sir. Dr. Tom, how do we manage acute kidney injury in snake bite envenomation?
Thank you, Ayman, for inviting me as a panel. So, as you all know, acute kidney is a end-stage organ damage as a result of envenomation. So, if you manage the envenomation with proper anti-snake venom and hydration and everything, usually acute kidney injury can be managed at the earliest stage. So, as Manusa said, when I started my practice 5 years back in KANNUR, I had seen many acute kidney injuries due to viper envenomation and everything. But recently, I think the numbers have reduced, probably due to better management with correct anti-snake venom administration. I think last year, only 2 snake bite death has happened in KANNUR district. So, probably better management. So, in acute kidney injury, the management is almost like any acute kidney injury management. You have to maintain hydration, avoid nephrotoxic drugs, and watch for worsening of acute kidney injury. Ensure correct monitoring of urine output. Watch for the electrolytes. Think of hyperkalemia. Maintain the fluid management with monitoring. If CVP monitoring or a POCUS IVC guided monitoring is possible, that would be useful. You should understand that acute kidney injury, the cause of acute kidney injury can be multifactorial. It can be a direct acute tubular necrosis due to direct nephrotoxicity. There can be hypotension due to hemorrhage and ATN. There can be rhabdomyolysis or myoglobinuria, hemolysis leading to AKI. There can be cortical necrosis due to severe vascular toxicity and also fibrin thrombi. So, in a series from PGI, around 70% of the acute kidney injury biopsies showed acute tubular necrosis. Around 10 to 15% showed acute cortical necrosis. All this were in 1989 times. So, they had seen the last stage of all this snakebite envenomation. So, apart from the initial management of supportive hydration and monitoring, the indications for dialysis are the routine, like refractory hyperkalemia, refractory acidosis, azotemia, severe oliguria and pulmonary edema. All the standard indications for acute kidney injury dialysis are only followed here, and only difference is that usually the AKI is hypercatabolic. It usually progresses very fast. So, we need not wait till the creatinine reaches 8, 9, 10 or if we know the progression is very fast and the patient will require hemodialysis, better to put the line early and start hemodialysis. That's the usual management regarding the acute kidney injury. Usually, apart from the acute kidney injury management with hemodialysis machine, the extracorporeal therapies are available for snakebite. I had reviewed one article from Professor K.S. Chu. He is called as the father of Indian nephrology. He is from PGI. So that article was in 1989 in Kidney International, and they had described regarding the management of acute kidney injury everything. So till now, I think in last 35 years, nothing has changed much in the management of acute kidney injury. Conservative management, hemodialysis when indicated, etc. But recently, some extracorporeal therapies and options are available for specific situation, not as first line, but after giving anti-snake venom, if the patient is deteriorating, if the patient is having severe thrombocytopenia, severe coagulopathy, schistocytes present in the lymph smear, and you know this, the TMA is worsening, patient is going into consumptive coagulopathy. There are few case reports and incidents where plasma exchange may be useful. The mechanism that is postulated is that the plasma exchange is done using the hemodialysis machine, in which the plasma of the body of the patient is removed and is replaced with fresh frozen plasma. So the principle is that it will try to remove the circulating venom, the antigen-antibody complexes, the inflammatory markers, the the hemolyzed blood particles, etc., and it will replace with plasma, good plasma. So this will try to reduce the storm and also the DIC and consumptive coagulopathy, and it may help the patient. So my first presentation in this IMA hall was in February 2022, and I had presented a case of salvaging a patient with DIC, with consumptive coagulopathy, and with alveolar hemorrhage after a few sessions of plasma exchange. At that time, I didn't have any experience regarding this thing, but after this, in last few years, I have seen that many case reports are coming regarding this topic. So I don't think there is definite guidelines or anything, because the evidence will be very limited. The evidence given is only category 3 evidence for plasma exchange, but in some cases when it is refractory, this can be considered. Then another thing that is heme adsorption. Heme adsorption can be done using hemodialysis machine, in which a HA230 filter. It's a cytokine filter. It will absorb inflammatory molecules which are kilodalton less than 50 kilodalton. So this snakebite toxins and inflammatory markers can be absorbed to a dialysis machine, and it can be used in situations when the anti-snake venom is not working, specifically in cases like Hamnos pit viper envenomation. We had two patients in which they didn't respond to ASV, and the snake was identified as Hamnos pit viper, and we tried 6-hour session of HA230 filter heme absorption, and the patient responded. And many case reports from Calicut, Dr. KANNUR from Astra Calicut, he also has supported many cases in which such cases has been managed. So extracorporeal therapy is coming up in specific situation in which the patient is not responding.
Mr. Manoj, if there is a snake inside my house, what I should do, whom I should contact? As
If there's a snake, there's a snake, there's a system within Kerala Forest Department. It's known as SERPA, and from 2020 onwards, after the Uttara murder case, this has come up where to bring accountability of who is capturing from where, and such things are now accounted. We have historical data where the number of counts of snake bite and in a particular region what snakes are found, which during which season, how they are active. All those historical data is coming up, past 5 years that is been on. To answer your question, the best way is, if you see a snake inside your house, stay away, call for help. In all districts, there are SERPA volunteers, and you can call them, they'll come. It's a voluntary service, but yes, people do charge. But better thing is to stay away. And people try to kill them. The law doesn't allow. The Wildlife Protection Act of 1972 had put around 17 snakes in Schedule 1, which accounts to 7 years of imprisonment and 1 lakh rupees fine. And Schedule 2 have the remaining 300 odd snakes. We have a population of around 350 snakes throughout India. 130 is found in Kerala, and 66 snakes are venomous in that, and only 10 are actually deadly. So better is to call up the forest department for help, so that all norms have been adhered, and accidents can be avoided. And currently, 5 years back, the death toll was around 140, and that has come down drastically because of the volunteers getting involved, and snake bites have come down drastically. And obviously, current scenario, when 140 was happening, nobody used to make claims, or there was nothing on the social media. Now the numbers have come down, so obviously, just to tarnish that image, or what has been built is been taken for a ride. A year back, Kerala Health Department and Kerala Forest Department joined hands to train give refresher training to doctors as well as nurses, basically to counter cases like anaphylactic shock or something. But obviously that did not materialize to an extent, it still remains in paper, but the snake bite count is coming down. People are celebrating, like people who are not part of the project are celebrating because the talk was about zero bite death policy. So few deaths here and there in the past 5-10 days have been celebrated big time over social media, which is basically an exaggeration. So 5 years back the number was around 140, now it's below 40. So we can actually compare and make the difference. On the longer run, a lot of states have come up to follow what Kerala is coming out with. States like Tamil Nadu and Karnataka had benchmarked Kerala's progress. Yes, Kerala can be much effective because of the size and the population what we have. Again, the health system within, if you go to North India, the health system, and as Sir said, all these malpractices have been around in all those states which where we are known as the capital of snake bite deaths. So WHO has already been working on getting the numbers to nearly 50% by 2030. And yes, to my understanding, the current central government has been acting on it, through a lot of process, including the new anti-venom, which can be universal for all snakes, are all been worked out. I know Karthik Sunegar, who is from Indian Institute of Science in Bangalore. The team is working on it, but to come on commercial line and to get it active, it might take few more years. So the coming years, we can see the results. Even as volunteers, Sarpa is doing a very remarkable job. But yes, people don't appreciate, one bite, obviously, all those things goes for a toss. Again, it's limited, as somebody from the panel said about CRIDE, all our living condition, all act to these sort of scenarios, which we can't completely, by getting some policy, you can't completely wipe off the whole living condition and other stuff, So this will continue, but the numbers will drastically come down, or even on the medical front, whatever treatment and the new developments what are coming in will get the numbers down for sure, and we'll leave that capital of snake bite deaths will eventually leave and be much safer. Thank you very much.
Thank you. Dr. Abhilash, what is the management protocol for hemotoxic envenomation?
Okay, now actually this is a very important part, one of the most important part of our discussion actually. So what we are following at district hospital and all the hospital here, the guidelines we are following is the national guidelines. So we know anti-snake venom, which is active against the big fours, that is viper group, rhesus viper and soft scale viper, cobra and the crate. So the crate management of as you already told. So how will we manage viper bite? We have 3 vipers which already mentioned, commonly bitten cases. So from the clinical scenario which we already mentioned, we will get a clue which type of venom the patient has, that is whether the bite the patient has, whether it is hemotoxic or neurotoxic. So when it is hemotoxic, the first and most important thing is we have to see the airway, breathing, circulation, everything. We have to put an IV cannula, start IV fluids, etc. And the most important thing in monitoring of the viper bite is whole blood clotting time. Whole blood clotting time is measured by taking 2 ml of blood in a test tube and keeping it for 20 minutes. And after 20 minutes, If the blood is not getting clotted, that means that the blood clotting time WBCT is positive, and it become positive as early as 30 minutes, but it can be delayed after even later also it can become positive. That's why we are monitoring the WBC clotting time. So the all blood clotting time should be monitored every hourly for first 3 hours. Then every 6 hourly. That is the every 6 hourly for 24 hours. That is the guideline actually. So if, then we should look for the lymphadenopathy, regional lymphadenopathy, whether there is any progression of the swelling. A localized swelling is okay. If it is progressing, the swelling and progressing means there is envenomation. Then whether there are any features of envenomation like bleeding is there, retrobentral hemorrhage, then capillary leak syndrome, etc., that all we have mentioned. If it is there, then we have to start anti-snake venom in viper bite. So indication for anti-snake venom in viper bite is lymphadenopathy, progressive swelling, positive WBCT, or if there is any features like bleeding, etc. of viper bite. So in that case, we have to start anti-snake venom. So anti-snake venom, you got the vials, it's actually a dry powder that we have to mix with 10 ml of distilled water. Then so if you are given 10 vials means 100 ml of mixed ASV will be there, that we have to put in 400 ml of NS and we have to infuse it. That's what we are doing. So there are, as per the guidelines, there are 2 types of infusion, that is low dose infusion therapy and a high dose infusion therapy. The low dose infusion therapy, the advantage is we have to use only small amount of ASV because ASV is very precious. ASV become minor the manufacturing very difficult. But only necessary situations only we can use ASV. The low dose infusion therapy means in a case of this rhesus viper, what we will give 10 vials of ASV in 30 minutes to 1 hour. In case of soft scale viper, we will give 6 vials of ASV. That is the first thing we will do. Then we will wait for 6 hours because the toxin will be neutralized and the body will have needs at least 6 hours to synthesize the clotting factors. So after 6 hours, we repeat the WBCT and also monitor the symptoms of the patient if needed. In case of low dose infusion, you give 2 vials as infusion in 100 ml for every 6 hourly until WBCT become negative or at least for 3 days, whichever is earlier. That is the guideline. When you are using high dose infusion, you can give 10 vials for both soft scale this rhesus viper, 10 vials of ASV we give as infusion or 30 minutes to 1 hour. Then every 6 hours we give 6 vials of ASV, 6 vials, and monitor WBCT and the swelling. Once the WBCT become negative, you can stop the ASV. That is the guideline what we are following here. And as told, there are so many pit viper bites. So when in our experience, what we do is most of the time the bystanders will bring the pictures of the snake and we will ask the patient whether this can you confirm this that this snake has bitten you. If the patient says yes, I am 100% sure, then we will take it as pit viper and of course monitor the patient also. And all the time we doesn't have to use ASV for pit vipers. It's very easy in pit vipers. And another thing is the development of other complications already mentioned, capillary, renal failure, etc. That also we have to monitor. And the WBCT monitoring is mainly for 24 hours. There are so many investigations that you can do, PTNR, APTT, etc., renal function, liver function, etc. That all according to the condition of the patient. So we use the ASV very cautiously. Is it precious? But of course we should use all the needed cases. Thank you.
Next, to Dr. Nandakumar, management of snake bite in children, is it anything different from what we do in adults?
So I already mentioned, there is no dosage difference in ASV because we are using ASV to utilize the toxin. The toxin injected, whether it is pediatrics or there is no difference. So the dosage is same, but the side effects due to the dosage is high in pediatrics. So especially the anaphylactic reactions are more in pediatrics compared to adult. So never ever give test dose. Why? Because this anaphylactic reaction is not due to Ig mediator reaction. It is complement mediator, it is idiosyncratic reaction. So if you would give test dose, while giving full dose, the first dose can act like a trigger and child can go for anaphylaxis. So to prevent this anaphylaxis, even we can try pre-medication with the adrenaline. That is usually in anaphylaxis we will give IM adrenaline. Here we can use subcutaneous adrenaline, half the dose. That is usual pediatric dose is 0.01 ml per kilogram. Here we can use 0.005 ml per kilogram adrenaline. Never you combine with hydrocortisone or avil. So only adrenaline. So in many hospitals we are trying this, but it's usually it is having benefit to prevent this anaphylactic because anaphylactic reaction more in pediatrics. So next is the fluid. So fluid is a double-edged weapon. You know, both cases. It can this majority of time oral fluid its hydration is issue, especially in children, because the body mass is very less. So the usual fluid what we are using is the 10 ml, that is same only. So total but for 10 vials will come 100 ml. This 100 ml, after this 100 we will dilute in 5 ml per kilogram body weight of normal cell. Then give it over 1 hour. That is what we are doing. Instead of what in adult total 500 ml, we are giving 5 ml per kilogram body weight. Otherwise, this overhydration already child is in hematotoxic, chance of renal failure is more. So again you are overhydrating, that is going to cause renal injury and other hyperperfusion injuries more. Next is the complications are more, especially this capillary leakage syndrome. So close monitoring, even though it should be there in adults also, but pediatrics should be very close monitoring is enough. And other drugs, especially if it is presynaptic, like trade is a presynaptic. Other this neostigmine is no way going to help you. But here you can try calcium gluconate. Calcium gluconate can prolong the respiratory issue, this paralytic issue. The 1 to 2 milligram per kilogram per day, we can try, we can repeat it after 30 minutes, we can repeat it. Then post-synaptic, we can try neostigmine and atropine combination. But if you are in a ventilated child, better not because atropine also increases this neostigmine will increase the secretion, but atropine will thicken the secretion. So it is a chance for the tube blockage is more if you give this combination along while in a ventilated child. So better to avoid the ventilated child. Next is these other drugs. Because this never use NSAIDs, already mentioned, never use of pain relief, give only paracetamol. No other business, only give paracetamol and no sedation for unless child is ventilated, definitely you have to be in a non-ventilated child, never allow child to sleep by monitoring the child. And other drugs are same thing only, there is no much difference. But the side effects of the drugs and the complication due to the toxins are much more, and the renal toxicity is definitely more in pediatric because the hepatotoxic, the venom injected is same. So all these organs are immature organs. So the effect will be much more in pediatrics than in adults. So we have to be very careful in pediatric, not in the pediatric, and we have to monitor the side effects of drugs as well as the side effects of toxins. Everything you have to monitor very closely in pediatric education.
Thank you, sir. As sir already discussed, anaphylaxis is one of the dreaded complication of using ASV, which makes, I think, the treating clinicians also hesitant in starting, that is taking a decision on starting ASV. So the thing what we can do is we become aware of identifying early anaphylaxis and managing it. So, Dr. Renoy, could you please highlight on this?
Yeah, so like Nirma said, most of the reactions are not pure IgE-mediated anaphylactic reactions. It's mostly, it is estimated 80% of it is complement-mediated reactions. You get itching, urticaria, all those things. So, as Sir said, test dose should be completely avoided. No, there is no role in test dose. It will only delay your ASV administration, and it can even sensitize for an actual anaphylaxis. So that should be avoided. What are the type of reactions? These complement-mediated reactions can be there. There can be pyrogenic reactions. You can have fever and shivering later, 2-3 hours later. Then later, you can have serum sickness type of reaction after a few days. So for the early reaction, the treatment is, as Sir mentioned, it is adrenaline. You can, there is some studies on prophylactic adrenaline. Like in Sri Lanka, there has been a study which they also use the Indian polyvalent dose, but their reactions are more. So they have tried 0.3 mg of adrenaline IM before starting ASV. That has shown to reduce the anaphylaxis. But Indian guidelines do not support this. That much reaction is not there in Indian population. And so the treatment, if these kind of symptoms develop, is first thing is immediately stop ASV, but which is only temporary. Do not, it is not a complete stoppage. Stop the drug, give adrenaline, and there is you can also give hydrocortisone, but it will act somewhat slowly only. So adrenaline is a major drug, and then wait for the symptom to subside. Usually you can restart the ASV within 30 minutes. You start restart the ASV somewhat slower. Usually the original doses you give within 30 minutes to 1 hour. You can, this time you start slightly slowly and you can increase the duration. So ideally you should completely finish. What we practice is, in our ICU, we keep an adrenal infusion ready standby usually. We put in adult patients we put an EJV catheter if possible, and keep the adrenaline connected and ready, not starting. And if once ASV is going, if these things comes, we start very slow infusion with the syringe pump. Otherwise, in other places, you can do an IM subcutaneous 0.5 mg of adrenaline you can use. So, if anaphylactic reaction develops, the treatment is, which is very rare, but the treatment is immediately give adrenaline, and most of the times you may have to give a lot of fluids also. Severe hypotension can ensue, and a lot of fluids, maybe even 2-3 liters of fluid may be needed sometimes in pure anaphylaxis. But usually the other symptoms can be managed this thing. And pyrogenic reactions you can treat with paracetamol and sponging and all. And later on, if the serum sickness kind of thing develops, they develop pain, joint pain, all those things, you can treat with the steroids and all those things.
Thank you, Dr. Reno. Dr. Manu Matthew, just enlighten us on what are the newer modalities in snake bite management.
Difference between the earlier management and present management, as a physician who has been working in Pariyaram for 2 decades, one is that snake identification has become now very easy, because there are so many WhatsApp groups. And earlier, when there was any doubt, when I joined there in 2004, whenever some weird snake will be there, it was very difficult to say it's poisonous or non-poisonous or whatever it is. Now it is very easy. You take an image and put it in the WhatsApp group, you will get the result in few minutes. And there are a lot of WhatsApp groups. One main WhatsApp group, there is 800 doctors are there, including the herpetologist. So all the main people in the SAPA group are there in the WhatsApp group. So if you put it in the WhatsApp group in the picture, immediately within minutes you will get the report what it is. The second one is, earlier it was very difficult. Suppose you see a snake somewhere in your compound, what to do, to whom to call. Now after these apps, SARPA app, then another one very good app is there, that is a Snake PD app is there. There also, if you want, you just go into the app and just look out for the KANNUR who are available. the list will be there, whoever it is there, in Kannur, Proper City, Srigandapuram, Talipuram, everywhere that list is there. So that aspect also is very good aspect, so that we can call the snake rescuer immediately. Then this neurotoxic snake bites, as you have seen, this LMA is there. Now they are going to implement it in the periphery also. 2 weeks back, there's now a zero snake bite death initiative by the government, and there was a training camp. I was one of the faculty a few weeks back in Kannur in Binale, and there we were giving training in how to insert the LMA. So in these high risk areas, if you train the people with this LMA, we can save lives. And we were also thinking how during the transport itself to give ASV. In many places they are doing like that. Then many new aspects are coming in snakebite management. There is a lot of newer tests as alpha phospholipase test is there, which will say whether it is a venomous snake or a non-venomous snake. Because a patient comes with snake bite, you do the test. If it is non-venomous, then you can discharge the patient. Then there is other tests like NGAL or neutrophil associated gelatinous lipocalcium 1 chemical is there. So that is an early marker for acute kidney injury. So if it becomes positive much earlier than creatinine. So if it is become positive, then from the periphery you immediately refer the patient to a tertiary center where there is renal support is there. Then there is other tests like phospholipase 2 inhibitors are there. So whenever snake bite is there, if you take the tablet, it will try to prevent the myotoxicity, it will decrease the myotoxicity and the neurotoxicity. So many therapeutics are coming in the pipeline. Then there is monovalent vaccine. Here we are using polyvalent vaccine. Some 4 big snakes we give, but it does not cover the sea snakes, it does not cover the king cobra, it does not cover our pit viper. So in Australia and all that, they are using the monovalent vaccine. They will first test and see which snake is that, and they will give anti-snake venom specific to that one. Here we are giving a cocktail, but we cannot go on adding the n number of snakes to that, because it will add up to the cost and also it will increase the adverse reaction. And nowadays, compared to the 2 decades back, we have a very good medical setup. A lot of nephrology centers are there. Even in Kannur, so many centers are there. So many ventilator support is there. So the snakebite deaths are also becoming very less. Earlier it was hundreds. Now it has become to 30s, less than 30s it is going to be. And our plan is to make it to near zero snakebite death initiatives there. And government is also very taking proactive measures for it.
Thank you, sir. We have covered most of the aspects of snakebite management. Just want to add 1 or 2 points. One is, of all the bites, 70% are actually non-venomous. Only 30% will be venomous snake bite, and of that also 50% can be dry bite, that is without any venom being injected. So the syndromic approach only with the clinical symptoms, if it is there, we are giving ASV. If it is not there, we are monitoring, because anti-snake venom, it's a precious thing, and it has to be used in the correct dosage. There is whatever is there in the guidelines, the exact amount should be given. And even if it is a non-venomous bite, we usually monitor the patient for 24 hours, because in case of crate, sometimes the symptoms can develop after 24 hours also. In West Bengal and all, the patient admitted for acute abdomen, after 36 hours they have developed ptosis. So at least 24 hours we are monitoring. If you have given ASV and the patient is stable without any target or other target organ damage, we can discharge the patient after 48 hours.
Thank you all, for this guided session.